This disease is actually the cases are actually arising in Malaysia, and this is quite worrying. And how the scientists are diagnosing it is by using many tools. At the moment, our lab at SASMAC, they are referring to WHO also. Okay, and the major tools in the diagnosis and also classification are morphologic review of the bone marrow, the blood cells, the blood smears, and also immunophenotyping. Saya rasa orang belajar immunophenotypes, CD23, CD5, and also they also use conventional cytogenetics. Karyotyping is still there. Yeah? And some labs they use FISH, fluorescence in situ hybridization. So this one's very accurate to the point where you can delineate very small abnormalities, very small deletions, and also, of course, there is PCR. To have this working nomenclature of leukemia, the WHO classification will combine all these morphologic, immunophenotypic, genetic, and also the clinical features. The clinical presentations of the disease of the patient. So this is done to get a biologically homogeneous entity of the disease, because somehow this disease, leukemia, can be different from one person to one person, even though they are diagnosed with the same type of leukemia. So in order to have a homogeneous entity, the WHO combines all this together with the clinical presentation of the patient. Right, can you see my next slide? I'll move on to the next slide already.
It doesn't move, doctor.
I've been trying since this morning. Mana dah nak buat what about now?
Okay, nampak dah. Acute leukemia.
Okay. So saya tak boleh nak keluar daripada sini. Okay, bila saya letak PowerPoint ni, saya tak tengok lah you all. Saya tak faham dekat mana saya. So, sekejap saya perlu guna dua lah. Dekat laptop, saya tak boleh tengok. Right. Alright, acute. We move on to acute leukemias. Okay, the first type. Okay, saya move. Kalau saya move macam ni, boleh nampak my third slide?
Boleh.
Okay. Saya yang tak nampak sebenarnya. Alright. The first type, okay, I will explain on AML, acute myelogenous leukemia. So, the symptoms of AML is caused by replacement of the normal bone marrow with leukemic cells. Okay, so this one will cause a major drop in all cells actually, in the red blood cells, the platelets, and also the normal white blood cells. Okay, so the patients are presented with symptoms like fatigue, shortness of breath, easy bruising. Okay, you can see purpura sometimes, and also sometimes it will come to bleeding, and also increased risk of infection. So as AML progress, it will progress rapidly and is typically fatal within weeks or months if you leave it untreated. Okay, so I have moved on to the next slide, yeah, clinical findings. Right. So these are the clinical findings of AML. Okay, the patients are presented with maybe not all of this, but some. Yeah? Some will present with hepatosplenomegaly, yeah, lymphadenopathy, which is enlargement of the lymph nodes, yeah? And evidence of infection, okay, hemorrhage, and thrombocytopenia, which I mentioned just now. A drop in all blood cells. Okay, gum hypertrophy, which sometimes can lead to bleeding of the gum, and also skin involvement, like I mentioned just now, bruises, and also purpura. Okay, okay. Some will involve CNS diseases, in severe cases. So these are the clinical findings, okay, purpura and ecchymosis. In this case, in a 12-year-old boy presenting with AML, and this is in the case of gum hypertrophy, okay, you'll see swollen, shiny, bleeding gingiva of on this patient. Um, okay, on peripheral blood smear, all right, patients are presented with pneumocytic pneumochromic anemia, which means that the size of the red blood cell is normal. The concentration of the hemoglobin in red blood cell is normal, and there will be decreased reticulocyte, um, uh, which is immature erythrocyte, and normal or depressed leukocyte count, myeloblast. Sometimes it may present with Ewell rods and also low platelet. Hmm. Okay, saya dekat slide staging system sekarang ya, betul?
Betul.
Alright. Okay. Right. There are two staging systems. Ya. Ada yang cakap apa-apa ke? There are two staging systems commonly used for AML. We have a FAB system or the French American British classification system. This one is based on morphology, and also this is to define specific immunophenotypes, and also the WHO system. Okay, we currently use that WHO system now, which will use the information on chromosome translocations and chromosome abnormalities, as well as evidence of dysplasia, okay, in the patients. Um, this is the whole. Oh, sekejap, saya tukar ni. Okay, this is the WHO classification system of AML. Quite complicated. You don't have to remember all because this one is actually in the textbook. Yeah? They have published a textbook on this. There is a combination of, as I mentioned just now, genetic abnormalities. Yeah? So you can see translocation 821, Q22, Q22. Okay, and also involvement of inversion of chromosome 16, yeah? And the presence of PML RARA, and also translocation. Okay, mostly the presentation is with translocation, recurrent cytogenetic abnormalities, and also um, okay, this is the presence of AML with translocation also, and this is when you see in the blood smear there is megakaryoblast. Okay, there are also provisional entity, and this one with mutated gene, what we call as RUNX1, yeah? And also neoplasms which are caused by therapy, unfortunately. Okay, And you can see that some in AML are diagnosed with the presence of myelodysplasia related changes. Okay, okay, this is EML NOS, not otherwise specified. Okay, these are the category different from those with translocation. Okay, so there are ML with minimal differentiation, those without maturation, and with maturation. Yeah? So these you can see from the blood smear. Um, Now is slide 11. So this is AML M0. Okay, so this is acute minimally differentiated AML. They characterized by lack of obvious myeloid differentiation. So the blast is less than 3%. The blast has small to large, no granules, no airway rods. Yeah? And this here in the slide here is an example of medium-sized blast in comparison to small normal lymphocyte. Okay, this is the medium-sized blast. Okay, this is the lymphocyte. Okay, and you can see the blast contain um, chromatin. Okay, clump chromatin, right, and prominent nucleoli. Yeah, yeah. Can you see my cursor? Because I've been pointing to the slide, but I'm not sure whether you can see or not.
Yes,
Can
we
you see my
can
cursor?
see.
Right. Good. Okay. Um, so this is slide 12, right? So this is the M1 type. Okay. Um, Here, there are 90% of blasts, myeloblasts, in the bone marrow or blood, depending on which sample you smear. Okay, and lack of any recurring chromosomal abnormalities. So the distinction between M1 and M2, not otherwise specified, is very vague because it merely depends on the blood counts. M1 is also known as AML without maturation. So the blasts here are large and also they are presented with prominent nucleoli. Yeah, right. So we move on to slide 13 and 2. Okay. Okay, this one. There is a notable eosinophilia in the blood smear here. Um, so you can see an increased numbers of mature eosinophils. Okay, so it will be stained. Um, how do I say pink? I don't know what you see, but here is very pink. Yeah. Um, there is also a prominent nucleoli. Okay. Right. All right. Okay. So this. Oh, sorry. So this is the arrow rods that I mentioned just now. Uh, the myeloblast can contain these long rods, what you call as arrow rods. Okay. This is actually abnormal condensation of cytoplasmic granules. Yeah? Usually presented in EML, and it confirms the myeloid nature of the blast, and also the presence of even a single well-characterized arrow rod in a blast of in the blood smear of a patient confirms the existence of acute leukemia. Yeah? So this is a very important diagnostic entity. So the rods are elongated bluish red rods, mm, composed of fused lysosomal granules. Okay, so this is the FAB classification of ML. The FAB system use numbers also from M0 to M7. Okay, so you can see 5% of adult AML patients have undifferentiated acute myelodysplastic leukemia, which is the M0 subtype, okay, and so on. The highest is M2, AML with maturation. All right, so we move on with ELL. So far, so good. I think I've put a lot of text on my slides, so I think my slides are um, understandable. Boleh?
Boleh, doktor.
Boleh.
Okay. Alright. Sekarang slide 17. Okay, so we move on to the next type. Boleh? ALL. Acute lymphoblastic leukemia, or some textbooks they use acute lymphoblastic lymphoma. So this is the modified WHO classification. Okay. Um, sorry. Predominantly, this ALL is seen in 85% of B cell tumor. Yeah. So the T cell tumors tend to be seen, in adolescent and males between the ages of 12 to 18. Yeah. Usually, ALL will affect children aged 3 to 10 years of age. And the differential diagnosis from AML is very important. So usually scientists will refer to textbooks to get clear view of AML and also ALL. So this is the classification. Okay. Um, you don't have to remember all of this. Again, this one is listed in the textbook. This is the precursor lymphoid neoplasm, B lymphoblastic leukemia, lymphoma, and there is also T lymphoblastic leukemia, lymphoma, although 85% of them are B cells originated. So the one with hyperdiplody, actually they have more than 50 chromosomes per cell. And this accounts for 25% of ALL cases. And this one is associated with trisomies, trisomies of the chromosome X, and also I have to refer my notes, chromosome 4, 6, 10, 14, 17, 18, and also 21. Okay, so I guess those with severe chromosomal abnormalities, okay, their prognosis is also not very good. Yeah. All right, so this is ALL B cell origin. Okay, most common in children, 80% of those are B cells, as I mentioned just now, and it is presented with CD10, CD19, CD79, also CD22, and immunophenotype. More than 20% lymphoblasts in the bone marrow, more than 20% in the peripheral blood. Yeah? So this is what you see here is hypercellular marrow. Yeah? 80% of the cells are presented with lymphoblasts. Yeah? So the patient here have symptoms like pallor, fatigue, which is caused mainly by anemia, and the patients are presented with skin involvement like ecchymosis and petechia, thrombocytopenia, and the patients have fever due to um, granulocytopenia. Oops. Okay, this is slide 20. All right. This is evenly distributed chromatin in the blast. Okay, so this is also a feature of lymphoid precursors, and less than 5% in normal marrow actually. So the morphologic distinction of this neoplastic lymphoblasts from normal actually is usually very difficult to be made. Yeah? How do you differentiate this from the normal marrow is you use immunophenotyping and also chromosomal um, distinction lah. Maknanya you find chromosomal abnormalities to find distinction between these two. Okay. All right. So we have finished with acute leukemias. Okay. We move on to slide 21, chronic leukemia. Yeah. Boleh saya move on? Boleh?
Yes. Boleh, doktor.
All right. So this is CML. So these are the clinical findings. Okay, so this is a 66. So this is a 66-year-old man with abrupt onset of widespread cutaneous eruptions. Sekejap ya. All right. Sorry for the interruptions. All right. Can you see my slide now?
Yes, doktor.
Right. Clinical findings, betul?
Betul.
Right. So this is actually a clinical presentation of an old man, 66-year-old man, with abrupt onset of widespread cutaneous eruption. So this is skin involvement lah. Yeah. You can see the purpurate patches, papules, nodules, on his back and also shoulders. All right, so this is a diagnostic criteria for apa ni, this myelogenous, MPN actually. Yeah. Yeah. So this is the major diagnostic criteria. You can see if you want to diagnose chronic leukemia, you have to go for the presence of Philadelphia chromosome or the presence of BCR-ABL genes. So the minor diagnostic criteria are leukocytosis. Usually white blood cell counts is around 100 times 10 to the power of 9 per liter. Predominance of neutrophils in both peripheral blood and also bone marrow, and also increase in myelocytes, absolute basophilia, greater than 200 cells per microliter, right? And also platelet count, either normal or increased. And if you are examining the bone marrow, there will be hypercellularity in the bone marrow. Blast is less than 5%. There will be megakaryocytes, although small, and there will be the presence of reticulin fibers in 30% of the patients. So this is the morphology. And we can see various stages of granulopoiesis and the presence of promyelocytes, myelocytes, metamyelocytes. Yeah, so band also segmented neutrophils. Kalau slide tak bergerak, tolong inform saya. Okay. So you can, if you see under the microscope, the promyelocytes usually presented with arrow rods. Okay, so this is the first picture. This is promyelocytes. This is the second largest stage in granulocytic series. So the color is reddish purple. The size is large. Okay. There will be granules. And these granules, they are, if you stain with peroxidase, they are peroxidase positive. And the cell size is around 12 to 20 micrometer. And the nucleus to cytoplasm ratio is less, usually from 3 to 1 to 2 to 1. Maknanya nucleus dia besar. Okay. Cytoplasm dia kurang lah. So figure number 2 is myelocyte. Okay, the nucleus to cytoplasm ratio usually is equal 1 to 1. Dia sama besar, sama size. So the chromatin is finely sorry, finely granulated, and also less aggregated. Picture number 3. Okay, you can see indentation here. So this is meta-myelocyte. Okay, promyelocytes, myelocytes, meta-myelocytes. So this one has a diameter of 10 to 18 micrometers, lebih kurang macam promyelocyte tadilah size dia. But ada macam dia punya rupa macam kidney. Dia ada indentation. There is indentation in the nucleus. So this one is a band neutrophil. Okay. Usually 1 to 2% of the peripheral leukocytes of chronic myelogenous leukemia patients have this kind of presentation. Okay, so you can see that the nucleus form a U shape, hence the name band neutrophil. So the chromatin pattern is it's coarse, usually it's clumped, and the cytoplasm is moderate to abundant. Okay. There are few non-specific granules and many specific granules. For the segmented neutrophils here in picture number 5, the nuclear lobes usually there are 2 to 5 lobes. So in this picture there are approximately 4 lobes. So this one is segmented neutrophils. The filaments are usually clearly visible. Chromatin pattern is like a band neutrophil just now. It's coarse and clumped. And the color is rose violet. The color of the granules is rose violet usually. So, okay, I hope you can remember all these patterns. Promyelocyte, myelocyte, metamyelocyte, okay, and also just now band and also segmented neutrophils. Okay. We have been going on for about 50 minutes or 45 minutes. Do you want to take a break? Do you want to take a break or do you want to continue? Continue je. Right. Okay. Next is CLL. We have done with acute leukemia, chronic leukemia, now is chronic lymphocytic leukemia, or there is another variant, what we call as small lymphocytic leukemia. Right. CLL, slide number 30. So this is a clinical presentation. Usually CLL affects elderly, 61-year-old man here in this figure presented with neck stiffness and also bilateral axillary discomfort associated with increasing diffusing lymphadenopathy. As I mentioned previously, this is actually enlargement of the lymph nodes. Right. So this is a smear showing the presence of 4 small neoplastic lymphocytes and also 3 smudge cells. So this one actually is very tricky. Sometimes we misdiagnose this with something else, or sometimes these smudge cells are merely because of technical error. So you have to be very careful if you are a hematologist in diagnosing CLL. Usually the characteristic is the presence of CD19 and 20, and also CD5 and CD23. So this one will help in achieving a homogeneous entity diagnosis of CLL. So, okay. This one, okay, we call this as soccer ball, because you see that the chromatin is clumped here. Sometimes seems like a soccer ball. The chromatin clumping and diagnosis can only be made using immunophenotyping for atypical CLL cells. So you can compare this with the neoplastic lymphocyte, this neoplastic lymphocyte with RBCs. We can see that this CLL cell is only slightly larger than the RBCs surrounding it. All right. So this is a typical morphology again. Okay. So you can see irregular nuclei. And also the nuclei is it has clefts and deep groove. So these are called reader cells, RIEDER. So diagnosis of this also along with immunophenotyping, we cannot simply rely on blood smear. So there must be presence of CD20, 19, CD5, and CD23, right? But from others, okay. Okay, this is the staging for CLL. Okay, there are 2 kinds of staging: the RISE system and also BINE system. For countries that use RISE system for CLL staging, these are the stages: stage 0, 1, 2, 3 to 4. For patients with RISE stage 0, they have lower risk of CLL. They have longer median survival, usually more than 10 years, whereas as the stages increases, the median survival decreases. For those with lymphocytosis, with anemia, either with or without enlarged lymph nodes, liver or spleen, this one is categorized as high risk, RISE stage 3. Right? And the median survival is 1.5 to 3 years. This goes also the same with lymphocytosis with thrombocytopenia, which you can see in rise stage for patients. So for the benign system, it has benign A, B, C. Okay, benign A is pretty much like rise stage 0 just now. The median survival is more than 10 years. And also for benign stage C is much like rise stage 3 just now. The median survival is 1.5 to 2.5 years. Yeah. So in stage C, the hemoglobin concentration is less than 10 grams per deciliter. The platelets is also decreasing, less than 10 to the power of 11 per liter. Right? So this is the genetics that you can use to pair with blood smear interpretation just now. Okay. So for those with deletion of 17p, yeah, patients with deletions of 17p, they have poor survival. Those with the presence of 17p13 and also 11q22 to 23 translocation, okay, they are associated with advanced disease. Okay, and those with 12q trisomy, 13q14 abnormalities, and also deletions of 13q, these patients, they have somehow a better prognosis and longest survival. Okay, right. So this is another variant of SLL, SLL. Right? So this is SLL is actually a common lower grade of B-cell lymphoma. There are pseudo follicles, and also they have also, when you see under the microscope, the bone marrow smear or peripheral blood smear, you can see the presence of soccer balls also. And there is a presence of CD5 and also CD23. So the clinical presentation, usually older patients are affected, median age 60 years, with 2/3 of them are males with disease in bone marrow, lymph nodes, spleen, liver, often presents with leukemia. Some patients are asymptomatic, and this SLL can progress to leukemic involvement, okay, with the presence of less leukocytosis. Almost all cases are B cell origin. Okay, median survival is 4 to 6 years, and it is indolent unless it transforms to aggressive leukemia. Okay. So this is a section of lymph node. You can see this cell. This is Reed Sternberg cells. Dia macam burung hantu, mata burung hantu. Okay. With abundant hemophilic cytoplasm, prominent nuclei in the background, numerous eosinophils, and this one in this picture, it stains with both acidic and basic dyes, so you can see both colors. So okay, for immunophenotype for both CLL and SLL, okay. Right, the immunophenotype is actually determined by flow cytometry. Okay, according to NCCN, also WHO for NCCN, there must be a presence of CD5 positive, CD10 negative, CD19 positive, and CD20 also dim. Yeah. For WHO, there must be a presence of CD5, okay, CD10 negative, okay, and also CD19 positive, okay. Slight different from the NCCN framework, okay. Yang ini boleh hafal saya rasa CD5 plus and also CD10 minus je ya. Yang lain tu you don't have to worry. Because I think this framework for, I'm not sure for 2020, saya belum check. This framework I got from, this one is from 2016 if I'm not mistaken. So there might be updated version of the immunophenotype.
Doktor,
Yeah.
can I interrupt? For CD5 plus and CD10 minus tu, CD10 minus tu maksudnya apa? Sebab saya tak faham.
Dah belajar immunophenotype belum?
Rasanya macam dah, tapi macam lupa yang CD10 minus tu minus what?
Saya rasa kena tengok balik ni nota immunology. Saya rasa
Okay.
yang ni Dr. Ridwan dah mention apa dia plus, apa dia minus. Saya tak tahulah Dr. Ridwan ke Dr. Fendi sekarang yang mengajar, tapi you have to know sebab sometimes if you cannot remember the plus and minus, bila dia bertukar tu, dia jadi diagnosis of a different entity of leukemia. So please have a revision on this. Okay. Saya tak tahu apa benda yang diajar dalam immunology, tapi saya pasti mesti ada pasal immunophenotype yang Dr. Ridwan dah sentuh. Okay, boleh saya move on sebab sikit je lagi. Sebab nanti kita nak masuk lymphoma kan. Banyak lagi. Can I move on? Kita habiskan leukemia, boleh?
Okay.
Alright. Okay, saya dekat slide mana dah ni? Slide 41. Alright, ATLL Adult T-cell leukemia. So dia interchange terms Adult T-cell leukemia or lymphoma. So this disease, this neoplasm, it is composed of highly pleomorphic lymphoid cells. Usually it's caused by HTLV1, human human T cell leukemia virus type 1. Sekejap ya, saya tengok epidemiology dia. Okay, usually it is endemic in southwestern Japan, parts of Central and also West Africa, South America. Okay, affecting those from 20 to 80 years of age, so very wide range of age. So the average is around 58 years. Most patients presented with widespread lymph node and also peripheral blood involvement. So these are the types of ATLL. So there is acute one. This one is aggressive type of ATLL. So the symptoms are most common in involving hepatosplenomegaly, elevated LDH, lymphadenopathy, hypercalcemia, and also lytic bone lesions. So you have to remember acute ATLL, it usually involves lytic bone lesions. And sometimes it is associated with opportunistic infections like the one that affecting the lungs, P. gyrovesi. Median survival of less than 1 year, okay, despite aggressive chemotherapy. So this one, this acute ATLL is very aggressive. So the next type is lymphomatous. This is also an aggressive type, found primarily in the lymph node. It will cause high blood white cell counts. There is also prominent lymphadenopathy. Most patients present with advanced stage, similar to the acute form. The chronic one is slow growing, so it can result in elevated lymphocytes in the end. Um, yes, so usually increase white blood cell counts. There is lymphadenopathy, hepatosplenomegaly. Okay, these patients can also have skin involvement like rashes, but no hypercalcemia. Yeah. For the smoldering ATLL type, this is also a slow growing type, very mild symptoms, very few skin lesions, and very few malignant cells in it. It has a slight lymphadenopathy, slight hepatosplenomegaly. WBC is usually normal. No hypercalcemia. So this chronic and also smoldering type, it can evolve into acute form in 25% of cases. Right. Actually, there is a fifth type that has been proposed, which is cutaneous ATLL. And this one has no leukemic phase, no lymphadenopathy, no hepatosplenomegaly, or hypercalcemia. Right. So this is okay. This is clinical findings of ATLL in a boy. Right. So there is multiple small erythematous papules on the outer rims of his ears. Okay. And infiltrated plaques on his upper limbs. Okay. So when they do a skin biopsy, they found that there is a diffuse infiltration of small irregular lymphocytes. Scattered bloods were observed. Histology was conclusive for unspecified T cell peripheral lymphoma. Um, so the morphology. All right. So the morphology is granular basophilic cytoplasm, multilobated nuclei. Yeah? It will form a pattern like clover leaf or flower cells. You can see that under the microscope. Okay, and also there will be thick nuclear membranes, coarse chromatin, distinct prominent nuclei. So um, in Hodgkin lymphoma-like cases, there will be Ritzenberg-like cells, and cutaneous infiltrates are either dermal or epidermal dermotropic. This one is quite tricky because you need to see under the microscope to see these portrait microabscesses. So this is what I mentioned just now, clover leaf pattern of ATLL. So this is one of the definitive diagnosis for ATLL. You can see this lobulated clover leaf nucleus of typical ATLL, and this is also um, circulating lymphocytes. In a patient with ATLL, again showing polylobated nucleus. Right. This is ATLL HTLV1 positive. This is also the presence of irregular nuclei, clover leaf shape pattern. There are indentations, lobulations, convolutions, and nuclear chromatin is mature, but the nucleolin is not prominent here. And the size of the lymphocytes is not a discriminatory finding here between acute and chronic forms, but in general, the chronic form has far fewer neoplastic lymphocytes in the blood. All right, this one, okay. This is a skin biopsy of a patient with ETLL showing dermal infiltrate, with epidermal tropism and microabscess in H&E stain. So epidermal tropism refers to the lymphocytes residing at the epidermis. Right. Okay. So to diagnose, you have to pair with immunophenotype CD2, 3, 5, but not CD10. Not CD7. And again, CD4, CD25, and rarely the presence of CD8. Okay, for ETLL. So I guess from here, from the slides, you can see that most of this leukemia, they have the presence of CD5 immunophenotype. Okay, can we take a break before I bring you to lymphoma slides? We take 5 minutes break. Now is 9:10 a.m. We will begin at 9:15. Boleh?
Boleh, doktor.
Alright, thank you. Boleh nampak first slide?
Saya tak nampak.
Belum lagi.
Sekejap. What about now?
Okey dah.
Okay.
Yes.
Screen ke bolehlah besar Kalau saya tak boleh buat presentation, saya klik presentation, you all tak nampak apa. Boleh nampak ni
Boleh, boleh.
Alright. Okay, ni first slide. Okay. Alright. So we have finished with leukemia. Now it's lymphoma. So this is also called as lymphoid neoplasms. So it comprised of a large group of clonal lymphoid proliferations. Same as leukemia, it has different clinical presentations. It has different pathologic features, biologic behavior, and more common in developed countries. Highest in incidence in US and also in the Europe. Slide saya bergerak ke? Slide number 2.
Betul.
Okay. Alright. Okay. Categories of neoplasm. Categories of lymphoma. So there are three major categories. B cell neoplasms, T cell, and also NK cell neoplasms, and also Hodgkin's lymphoma. So actually immunophenotyping and also molecular genetic studies are not needed in all cases, but can be very important in some, because you need to differentiate between the fine lines of some B cell neoplasms. So lymphomas and lymphoid leukemias, they are all included in the WHO classification. Again, I mentioned in my last slides on leukemia and on CLL. Okay, BCLL and also BSLL is actually a different manifestation of the same neoplasm. They are lymphoblastic lymphomas and also acute lymphoid leukemias. There are also Burkitt lymphoma and also Burkitt cell leukemia. So both solid and also skeletal phases are present in many lymphoid neoplasms, and distinction is somehow almost artificial. So this is the whole classification of lymphoid neoplasms. So this is the 2016 version. Maybe there is a 2018 version now. But again, you don't have to remember every single one of this. There is a textbook that WHO has published on this. I guess the 2020 version is also available now, but it's not yet. I do not have the textbook yet. So this is the 2016 version. So because it is impractical to list all the B and also NK or T cells neoplasms, according to prognostic groups, the WHO has actually arranged according to differentiation stage, predominant clinical presentation, which include predominantly the disseminated disease, which involve bone marrow, and can be leukemic. Those that involve the skin and also GIT, ada yang involve GIT, and predominantly nodal diseases that are often disseminated, and this one can involve extra nodal sites. And this is also another classification on this one is on T and also NK cell neoplasms. Okay, you can see that they have divided to the precursor neoplasms and also mature neoplasms. As mentioned just now, there is a predominantly disseminated extranodal and also predominantly nodal neoplasm. Another one is Hodgkin's lymphoma. Okay. So this one, these are the classical subtypes: nodular sclerosis Hodgkin lymphoma, mixed cellularity HL, lymphocyte-rich HL, and also lymphocyte depletion HL. Okay, there is also another subtype, another type which is called nodular lymphocyte predominant Hodgkin lymphoma. Okay. Okay, we'll move on to NHL, non-Hodgkin's lymphoma. So the pathophysiology is it includes genetic alterations such as activation of proto-oncogenes and also disruption of the function of tumor suppressor genes. And the infectious agents that play a role in the pathophysiology of non-Hodgkin lymphoma is EBV in a proportion of classical NHL, in a proportion of classical HL also can be found. Nearly 100% of endemic Burkitt lymphoma and 40% of sporadic cases involve ABV infection. And also in Kaposi sarcoma associated herpes virus, this one is found in association with lympho proliferation and the involvement also of HTLV1, macam ETLL juga, and the involvement of hepatitis C virus with splenic lymphoma and involvement of bacteria in extranodal B cell marginal zone lymphoma and also the multi lymphoma. For example, Helicobacter pylori infection, which is associated with gastric malt lymphoma, and also Borrelia burgdorferi in the pathogenesis of cutaneous malt lymphoma. On immunologic status, this one plays roles also in the pathophysiology of NHL. Immunodeficient patients have actually an increased risk of developing lymphoproliferative disorder For example, the salivary gland lymphoma patients, they also develop Sjogren's disease, and thyroid lymphoma in patients with who also develop Hashimoto's thyroiditis. I think maybe you have actually learned in pathology that Hashimoto thyroiditis is um, apa ni, a disease associated with immunodeficiency. I'm not sure, but you can search on Hashimoto's thyroiditis. Okay, the first NHL is follicle lymphoma that I will explain to you. Okay, so this is this type of lymphoma is actually the second most common B cell NHL in US after diffuse large B cell lymphoma. So 45% of lymphoma of follicular lymphoma affects the adults in the US and also Western Europe. It is named as follicular because it has nodular pattern of growth. It has no diffuse with or without diffuse areas, and this form of lymphoma is always a disease of adults, very rare in children. Yeah? Right, these are the clinical features of follicular lymphoma. Patients with follicular lymphoma generally present with asymptomatic lymphadenopathy. And the bone marrow involvement is present in 70% of patients, whereas involvement of other normal organs is uncommon. And less than 20% of patients present with B symptoms, and also less than 20% of patients present with increased LDH, like dehydrogenase. And B symptoms here refers to night sweats, fever, and also weight loss, right? And involvement of the intestine is a unique site of presentation of this disease, usually at early stage, which recommends favorable prognosis. And pediatric FL is a distinct entity, although rare, it can happen. The disease presents with localized disease. There are 3 stages of histology, and usually FL in adults, they are presented with BCL2 rearrangement involvement, but there is none in pediatric FL. And pediatric FL is highly curable. So this is the nodular pattern. Yeah? Round to oval structure comprised of follicular B cells distributed evenly throughout the follicle with no definition of light or dark zones of normal lymphoid follicle. Yeah? This is also another one, predominant population of larger cells in this neoplastic follicle without any light or dark zones and lack of obvious mantle zone around the follicle. And this is on immunophenotype and genetics of FL. So diagnosis is based on histology of preferably biopsy or lymph node. And in all cases, there is CD 19, 20, 10 monocular immunoglobulin as well as cytoplasmic expression of BCL2. Yeah? And the majority of cases have trisomy, 14-18 translocation, yeah? And also involving the IGH BCL2 gene rearrangement. All right. So for prognosis, okay, for those age 60 or below, Surprisingly, they have good prognosis, but those above 60, they have poor prognosis. And also stage 3 and 4, for those with hemoglobin less than 12 gram per deciliter, more than 4 lymph node areas affected, and high LDH. All of these have, if these patients have all of this, they have poor prognosis. Right. We move on to the next NHL, diffuse large B-cell lymphoma. This one is among the highest, ranked the first in the US, most common type of NHL. Median age, usually the patients affected are around 65 years of age, and it has a slight male predominance. So these are the clinical features, okay, B symptoms, fever, night sweats, just now. And also these clinical manifestations, um, they are diverse. They depends on the site of disease involvement. So the tumors have a rapid growth rate, yeah, and present as masses. It will cause symptoms when it infiltrate tissues or it obstruct any organs in the body. And pain in pain in enlarged lymph node or organ may be noted if lymphomatous mass enlarge in a quick manner. So as with other types of NHL, the LBCL can present with uh, here B symptoms, generalized pruritus, uh, like drenching night sweats, weight loss, and other symptoms can follow like anorexia, pedal edema, which is caused by extensive um, pelvic lymphadenopathy, and fatigue, chest discomfort, shortness of breath, which is caused by mediastinal lymphadenopathy. And these are the morphology of the LBCL. Yeah. So it depends on histological subtypes, which are centroblastic in 80% of the cases, immunoblastic DLBCL in 10% of cases, and centroblastic polymorphous in 10% of cases. Okay, so the centroblastic polymorphous, there are features intermediate between centroblastic and also immunoblastic. Okay? It is not a single entity, but a group of B-cell lymphomas that share two morphologic elements. Okay? So here, this is an example of the LBCL, which shows immunoblastic morphology with large cells containing moderate to abundant hemophilic cytoplasm, usually with a single nucleoli. Okay, the nucleoli is prominent, yeah, and you can compare the size of immunoblasts with that of small lymphocyte, long arrow. Okay, um, excuse me for a while. Okay, sorry about that. Where were we? So I have mentioned on the arrowhead just now. Okay, so you can see mitosis. Okay, mitosis here. Okay, that is happening at the time this plasmid is made. So, all right, this is the immunophenotype and genetics of the LBCL. Okay, so it co-expresses pan B cell markers, including CD19, 20, 22, 79A, and also CD4, 5RA. Yeah? And the nuclear transcription factor PAX5. So germinal center associated markers are CD10 and BCL6. Yeah? They are expressed in 30 to 40% and 60% respectively. BCL6 expression has been associated with prolonged progression-free survival and also overall survival. Yeah, when the patients receive rituximab as chemotherapy. And on the other hand, here we have CD5. This one is expressed in only 10% of patients. So its expression should raise suspicion of transformation from a more indolent form of NHL, such as SLL or CLL, and it has been associated with a shorter survival. Yeah? So usually, actually CLL can transform to the LBCL, okay? Or SLL can transform to the LBCL if they have CD5. If you see CD5 as immunophenotype in the LBCL subtype, usually the hematologist will suspect that it is transformed from a more indolent form of non-Hodgkin lymphoma. So when you use a fish, okay, you will reveal more chromosomal translocation, such as 3q27BCL6, which occurs in 55% of patients with the LBCL, translocation of 1418, which occurs in 15 to 20% of patients with the LBCL, and translocation 814 occurs in less than 5% of patients with the LBL. P53 mutation happens in almost all cases with the LBCL. Okay? So P53 is actually a tumor suppressor gene. Yeah? So when there is a mutation, there will be a rapid acceleration of rapid progression of this disease. All right, these are the special subtypes of the LBCL. And first, the immunodeficiency associated large B-cell lymphoma. So this one present with latent EBV infection. Ya, maknanya patient tu dah pernah ada infection EBV before. And also another one is body cavity large B-cell lymphoma. This one is diagnosed in patients with HIV and those infected with human herpes virus 8. Yeah? So it arises as malignant pleural or ascitic effusions in these patients. So these are the prognosis of the LBCL. Kat berapa nampak Actually, the LBCL is curable in half of cases with the current therapy using monoclonal antibody. The prognosis is highly associated with IPI score of International Prognostic Index score. Yeah? So they'll, sorry, actually the current treatment is doxorubicin. Okay, monoclonal antibody is also used and has been used for years and treated the LBCL despite having, despite of its aggressive or rapid progression nature. This is the IPI. Patients are usually aged more than 60. The LDH is above normal. Okay, and AHBS stage 3 or 4, and there are involvement of extranodal sites of more than one. Okay, so the score is given according to numbers like here. 0 to 1 is considered as low risk group. Okay, the 5-year overall survival is 73%, and also for the score 0 to 1, the 3-year emission, sorry, I forgot about this, EFS. I will get back to you on this. I forgot. For PFS, 3-year progression-free survival is 87%. Yeah? For 3-year overall survival is 91%. So you can see that the higher the score, the shorter the progression-free survival and also overall survival. Yeah. There is another index which is age adjusted. For the score, all the prognostic factors listed above, with the exception of age and number of extranodal sites, are given 1 point. So this is the age adjusted IPI. Dia tak ambil kira number of extranodal sites involvement. Dia tak ambil kira age. Again, you can see that those in high risk group, the 5-year overall survival is 21%, is even lower, even shorter. Yeah. All right. Okay. So if you want to know more about IPI, you can refer any textbooks in the library, or you can even find relevant articles on IPI, because sometimes there are necessary situations where you have to use age-adjusted IPI to diagnose the LBCL. Okay, so I think we have completed on the LBCL. Okay, so the next NHL is marginal zone lymphoma. All right. Okay, so this is actually a peripheral B-cell tumor. Accounts about 5 to 10% of patients, and this one is considered indolent or slow growing. So extranodal marginal zone B-cell lymphoma, or EMZL, is also known as MALT lymphoma. So I have mentioned in my previous slide on MALT lymphoma. Another type is nodal marginal zone B-cell lymphoma, and the third type is splenic marginal zone B-cell lymphoma. So the clinical features of EZML depends on the tissues involved. For example, if it involves the gaster, patients with gastric EZML can present with gastroesophageal reflux, epigastric pain or discomfort, anorexia, weight loss. For ocular adnexa, this may present with slow-growing mass, eye redness, epiphora, which is excessive eye watering. Those with salivary gland EZML may present with slow-growing mass. Minority will have bilateral involvement. Skin EZML, patients with primary cutaneous marginal zone lymphoma, they have a red papules, plaques, nodules, usually at the trunk or upper extremities. Those with lung EZML, they can be asymptomatic, but they have lung nodules and or airspace consolidation on imaging. Small intestine, patients with a small intestine is ML. They have intermittent diarrhea, colic, colicky abdominal pain, symptoms related to malabsorption. So the disease association, increasing evidence suggests that AZML is related to chronic immune reactions due to bacterial, viral, or autoimmune stimuli. Yeah? Depends on the presence of activated antigen-driven T cells. For that, the patients with AZML can display evidence of autoimmune disorders and involvement of Helicobacter pylori. Okay, so for autoimmune disorders, patients with autoimmune disorders, okay, they have Sjogren's disease, Sjogren's syndrome, systemic lupus erythematosus or SLE, relapsing polychondritis, Hashimoto's thyroiditis. Yeah? So this one can happen with or without coexisting infections. And also, more than 90% of patients with gastric AMZL are Helicobacter pylori positive. All right. So, okay. Like other NHL, nodal marginal zone lymphoma is more common at advanced ages. So there is no clear factor that predispose to this disease. It can be more common in individuals with chronic hepatitis C infection, autoimmune conditions such as hemolytic anemia, immune thrombocytopenia can also be associated with NMZL, and also SMZL. Marginal zone lymphoma does not appear to be hereditary, so you don't have to worry if you have this lymphoma. So, I mean, it won't be passed to generations. So this is a marginal zone, nodal marginal zone lymphoma just now. A single almost naked germinal center, which is in here. Yeah, is present surrounded by neoplastic marginal zone cells. Right. So actually, you can see that this is very homogeneous. It's not easy to tell unless you can clearly see this germinal center here. Okay? All right. This is on immunophenotype and genetics. Okay. So there is presence of immunoglobulin, surface immunoglobulin, CD19, 20, 32, and also 79A. CD5 and CD10 is there, and also the presence of CD23. Okay, so patients are also present with trisomy 12, okay, in NMZL and 7q deletion in SMZL. For EZML, the patients have a translocation of chromosome 11 and also 18. So you only have to remember all these three subtypes and also the genetics of it. All right, these are the prognoses. Okay. The prognosis of those with of this Mule lymphoma is often quite good. Okay. Patients with limited stage Mule lymphoma, extranodal one, can be treated with curative intent, with antibiotics or locally directed therapy, and also um, the patients can the patients with advanced stage lymphoma or those with relapse can do something with for example, can opt for allogeneic stem cell transplantation. But 5-year overall survival of patients with mild lymphoma is around 80% actually for older individuals. And those with aggressive transformation, somewhat they have somehow they have a worse OS than those with mild lymphomas, with a reported 5-year OS closer to 60%. So the difference in OS is likely due to biological differences between the two types. Okay, although precise differences need further elucidation. All right. Okay. We move on to mantle cell lymphoma. Okay, so these are the clinical. Um, this is actually an aggressive form of NHL originating in the mantle zone. Usually occurs in 6% of NHL cases, yeah, and is diagnosed in at a later stage of disease. Most cases will involve GIT and also bone marrow. There is a overproduction of cyclin D1. Yeah? So identification of this excess cyclin D1 is a very good tool in diagnosing MCL. Yeah? These are the clinical features. It involves multiple lymph nodes and sometimes extranodal. Okay, and in the throat, usually tonsils and adenoids. In the liver, in the GIT. Okay, these are the sites that are always involved. Apart from spleen, marrow, and also blood, and also lymph node, of course. And patients with MCL, they actually suffer from weight loss, fever, night sweats. They have abdominal pain or bloating, feeling of fullness, discomfort. Commonly seen complications like low blood count or cytopenias, right? And GIT, pulmonary and also CNS complications. Multiple small intestine polyps can also be detected in patients with MCL. Right. What else? Okay, leukocytosis. This is high white blood cell counts. This is common in patients with MCL. Right. So this is the morphology. Okay, in patients with MCL, these are the cytologic variants. The first one. Kita macam ni. Okay, the first picture A is mantle cell lymphoma of the classic variant. B is MCL of the small cell variant, and C is blastoid mantle cell lymphoma, and D is pleomorphic MCL. Alright, so they have a small cell variant with small and round cells. The blastoid MCL here, they have slightly irregular nuclei. The pleomorphic type here is composed of heterogeneous population of large atypical cells. They have cleaved nuclei, vesicular chromatin distinct nuclei. Nuclei tak sepatutnya nampak, but the pleomorphic type, you can see in the pleomorphic type, you can see the nuclei. So abundant mitosis are also seen. Okay, this is a magnified version. Large pleomorphic cells, variant of mantle cell lymphoma. Yeah. All right. This is evidence of mitosis. Compare the size of large cells with the small neoplastic cells. Okay, so this is the immunophenotype and also genetics. So MCL expresses a mature B cell phenotype, CD19, 20, 22 PAX5, CD79A, and also the presence of surface immunoglobulins M and also D. Yeah? And it also co-expresses CD5, but it can actually be negative in up to 10% of MCL. Yeah? And the tumor is also positive for BCL2. Yeah? Okay, BCL2, CD43, and also MFC7. Okay, well, most cases are negative for CD23, 10, BCL6, CD200, and also LEF1. Okay, and expression of cyclin D1 is a highly specific phenomenon in MCL, very useful to diagnose MCL. In the presence of SOX11. This one is a neurotranscription factor, highly expressed in most MCL cases, virtually negative in most mature lymphoid neoplasms. So can also be used as a diagnostic factor. And this is a cytogenetic characterization in MCL, translation of 1140. Okay. 90% of MCL display highly altered genomes. There are gain and also amplifications, and also homozygous, heterozygous losses, a part of other non-recurrent chromosomal rearrangements. And then apart from tumor suppressor gene mutations, other genes have also been notified apart from ATM and also P53 genes like Notch1, Notch2, NST, MEF2B. More rarely is mutations in the NF-kappa B. Yeah? All right. So this is the model proposed in 2007 by Jarvis and colleagues. The model of molecular pathogenesis and progression of MCL, okay, from naive B cell, okay, there is a translocation of chromosome 1114 and also cyclin D1 overexpression, which block RB1, also P27. Okay, early MCL. Okay, before it turns into classical MCL, there is ATM and CHEK2 mutation, which will lead to complex karyotypes. Okay, from classical to blastoid MCL, there are much more genetic alterations here, like MDM2 proliferation, RB1, CDK4, P53 mutation. So this one will lead to high proliferation of mantle cells, lymphoma cells lah. Okay, prognosis. Okay, so the median progression-free period is actually 20 months. Median overall survival is between 5 to 7 years. So the prognosis is poor for the blastoid variant. This type of MCL typically progresses after chemotherapy. So we are in need of better treatments. Okay. Right, we move on to Burkitt's lymphoma. Okay, so far so good.
Yes.
banyak ya lymphoma. Lymphoma ni ada banyak, so I don't think we can cover multiple myeloma after this. It's too much for you to handle, I think. So we will include multiple myeloma in our next class on Monday. Boleh? Boleh?
Boleh.
Right. So, Burkitt's lymphoma actually identified in 1956 among African children. Okay, common in young children who also have malaria and also EBV infections, Epstein-Barr virus infections, which cause infectious mononucleosis. Okay, so the other mechanism is that the malaria itself weakens the child's immune system in response to Epstein-Barr, which allows it to change into infected B cells, allow it to change to cancer cells from infected B cells. So 98% of these African cases are associated with ABV infection. So outside Africa, Burkitt's lymphoma is rare. In US, actually 59% of their patients are around age 40 and above, and it is likely to develop in people with HIV infections. Right. So there is these types, the endemic, sporadic, and also immunodeficiency associated Burkitt's lymphoma. So the endemic Burkitt's lymphoma usually affects African children of 4 to 7 years of age. The sporadic ones, this one occurs worldwide. Usually 1 to 2% of cases in the US. Immunodeficiency associated, this one accounts for 30 to 40% of patients with HIV, and can also occur in people with congenital conditions which cause immune deficiency, and also those who receive organ transplant, who are under immunosuppressive drugs. So compared to the endemic type, the incidence of the EBV infection is considerably lower in sporadic and also immunodeficiency associated Burkitt's lymphoma. With immunodeficiency associated type, it occurs in around 30 to 40% of patients. So these are the clinical features. The endemic variant usually involves extranodal sites. Okay, the endemic variant usually starts as tumors of the jaw or other facial bones. It can also affect the GIT, the ovaries, the breast, and can spread to the CNS, causing nerve damage, weakness, and also paralysis. And the types more commonly seen in US is the sporadic and also immunodeficiency type. And these variants can start in ovaries, testes, and also other organs. Other symptoms associated with Burkitt's lymphoma include loss of appetite, weight loss, fatigue, night sweats, and also unexplained fever. So these are actually the typical B symptoms that are affecting other leukemias and lymphoma patients. All right. Okay, so this is the morphology of Burkitt's lymphoma. Usually they share the same histologic features, including they have some kind of diffuse architecture, medium-sized lymphocytes with scanty neoplasms, cytoplasms. What else? Presence of numerous tangible body macrophages. This one represents apoptotic cell debris. Right? So this is a typical low magnification picture of the starry sky appearance, and caused by abundant large histiocytes. So this is also a feature of Burkitt's lymphoma. Right? All right. Immunophenotypes and also genetics of Burkitt's lymphoma. Um, Burkitt's lymphoma is a B cell lineage. Okay, so it expresses B cell antigens like CD19, 20, 22, and B cell associated antigens like CD24 and also HLA-DR. Okay? Also co-express immunoglobulins, usually immunoglobulins M, and juvenile center markers like CD10 and also BCL6. Okay? And they are negative for CD25, 30, TDT, and also BCL2. Okay, for genetics, the Burkitt's lymphoma are characterized by high levels of mite overexpression or mite expression, yeah? um, due to chromosomal translocations and also mutations of the mite gene. Yeah? And chromosomal translocations occurs in virtually all cases of Burkitt's lymphoma, associated with translocation of the long arm of chromosome 18, the site of the mite gene, and one of the three immunoglobulin genes. Yeah? Right. So for prognosis, Burkitt's lymphoma, if left untreated, can bring death to the patients. So in children, if there is intensive chemotherapy, it will usually cure them, yeah, leading to long-term survival rates of 60 to 90%. Yeah? Right. Uh-huh. Right. Okay, so this is actually I got this from haematologyoutline.com. Okay, you can actually see the genetics abnormalities and how you can memorize the genetic abnormalities based on this apa ni, triangle. For mantle cell lymphoma, translocation of chromosome 11 and 40, T1140. For follicle lymphoma, T1480. For extranodal marginal zone EMZL, sorry, is translocation 1118. Yeah, right. So for Burkitt's lymphoma B, you can associate it with 8, translocation 814. Okay, so this is just a way to memorize. Okay, so can I move on? Boleh?
Boleh.
All right. So the next one is mycosis fungoides, okay, or Sézary syndrome. So this is actually an indolent disease. It is a T cell disorder, typically present with various skin disorders for years. So the patient suffer from erythrodermic phases, which begins with eczema, dermatitis, and then they move on to psoriatic like lesions, plaque tumor later will affect the lymph nodes and other organs of the body. Right? Whereas there is a disease called Sézary disease is sometimes considered a late stage of this mycosis fungoides. All right, so this is the three clinical morphologies of mycosis fungoides, the patch, plaque, and also tumor. So each is differentiated from the former by increasing thickness. Okay, so the patch stage, figure 1 here, Okay, the patches are flat to atrophic lesions, usually erytheromatous with variable amounts of scale, and can resemble eczema. Atrophic lesions have cigarette paper, wrinkle appearance. Okay, and the plaque stage here, the plaques are raised or indurated lesions, and the affected sites are considered plaques. Dia macam dia macam nak cakap, dia terangkat sikit. Dia punya lesions tu boleh rasa lah. So tumor stage here, okay, tumors exhibit a significant vertical growth. Okay, must measure at least 1 centimeter in diameter. They are often ulcerated. Ini memang dah teruk lah. Okay. Alright, so these are the three recognized mycosis fungoides. Okay, so these subtypes are also can be recognized, diagnosed using WHO classification, and also European Organization for Research and Treatment of Cancer. So there are three features: folliculotropic mycosis fungoides, pagetoid reticulosis, and also granulomatous slack skin. Okay, so for folliculotropic mycosis fungoides, these are the clinical presentations, and these are the immunophenotype. And usually, histologically, you can see follicular tropism, variable infiltration of eccrine sweat glands by atypical lymphocytes. And for pagetoid reticulosis, there is hyperplastic epithelium with marked pagetoid-like atypical lymphocytes. For granulomatous slack skin, there is a dense granulomatous dermal infiltrates of atypical lymphocyte. Okay. All right. So for patients with Sjögren's syndrome, okay, they typically present with erythroderma, defined as diffuse erythema, affecting at least 80% of body surface area. And for patients with folliculotropic MF, the lesions are affecting the head and also the neck area. Okay, when located within hair-bearing areas, it may cause alopecia, atau kebotakan lah. Patches or plaques can be composed of cyst-like or follicular-based papules, like this. Right. So for all of this, these are actually the clinical images of MF or SS, used for reflectance confocal microscopy. So this is the presence of erythematous patch. This is a hypopigmented patch, and the presence of plaque here. This is hyperpigmented patches, and the presence of papules here. Erythroderma on the skin, diffuse erythroderma, ini tak apa nampak, and peripheral follicular papules. This one can be touched. You can feel it because it is raised. And poikiloderma. So for the morphology, okay, the malignant cells are small to medium size with irregular nuclei. The nuclei pattern is cerebriform. Larger cells can be present, which are the classical caesary cells, but be in minority. Cerebriform nuclei. So, the prognosis, okay, depends on clinical stages. So, clinical stages is important in determining the risk of disease progression and also overall survival. The staging refers to WHO or European Organization for Research and Treatment for Cancer. Right. We are done with MF and also SS. Okay. And we are done with non-Hodgkin lymphoma actually. So I move on to Hodgkin lymphoma. Boleh? Boleh?
Boleh tu.
Okay. Yeah. Okay. So I think if you search for this disease, you may find that some website use the term Hodgkin's disease. So this is actually a type of lymphoma. This is a cancer of the lymphatic system, mostly affecting young adults 15 to 35 years of age and also older adults over 50 years of age. Usually common in Caucasians and also African Americans. Because of progress in treating Hodgkin lymphoma, most people will survive with long-term overall survival. Right, so this is the types and also subtypes of Hodgkin's lymphoma. So it is divided to classical and also nodular lymphocyte predominant HL. Okay, so for the classical HL, there are nodular sclerosis, mixed cellularity, lymphocyte rich, and also lymphocyte depleted types of Hodgkin's lymphoma. So for nodular sclerosis, NSC HL, this one is the most common type of Hodgkin disease in developed countries. So it counts for 7 out of 10 cases in developed countries. The cancer cells are the classical HL cells, which are the red Sternberg cells. So for NSCHL just now, okay, it starts in the lymph nodes and it can begin in the neck and also the chest. For mixed cellularity, this is the second most common, also found in children, also elderly, can start in any lymph node, but always occur in the upper half of the body. For lymphocyte rich, this one is not common, usually occurs in the upper half of the body. And for lymphocyte depleted, this is a rare form of Hodgkin lymphoma. But it's more aggressive than the other 3 types of HL, likely to be advanced in the first round. It's most often in lymph nodes in the abdomen, as well as in the spleen, liver, and also bone marrow. Right. So these are the clinical features of HL. Okay, the patients can present with asymptomatic lymphadenopathy, B symptoms, intermittent fever, chest pain, cough, shortness of breath, pruritus, pain at sites of nodal disease, and also back and bone pain. For the morphology, as I mentioned just now, patients with HL usually have red Sternberg cell. Okay, we move on to morphology. Next, morphology. So this is the nodular sclerosis type of HL. The red Sternberg cells here, okay, it can take many forms, including mononucleated and also multinucleated forms. So this one is multinucleated red Sternberg cells with many nuclei containing distinct nuclei. Maknanya boleh nampak dia punya nuclei. Banyak nukleus. Right? So for okay, this one is another example of nodular sclerosis HL. Okay, there are some mononucleotides some are binucleated. Okay, the red stem cells are surrounded by smaller lymphocytes and also eosinophils and also histiocytes. Macam ni binucleated, kita nampak. Alright, so for the immunophenotype, CD30 and CD15, CD30 is expressed in almost all cases of Hodgkin lymphoma, whereas CD15 is expressing up to 85% of cases. CD45 is not presented by patients with HL. B cell antigens, there are CD20, 79A, and or CD19, which is characteristically either absent or seen only in a subset of red stem cells. For T cell antigens, the pan T cell antigens like CD3 and 7, they are not expressed by HRS cells, red stem cells. But expression of single T cell antigen, for example, CD4, can occasionally be seen. For PD1 and its ligands, these red stem cells, they express PD-L1 and also PD-L12. Okay, Epstein-Barr virus antigens. Okay, these are expressed in positive cases of ABV, cases of classical HL. And the tumor cells express EBV latent membrane protein, LMP 1 and 2. Okay. Other antigens like CD25, HLA-DR, and CD95, they can also be present in HL cells, HL patients. Right. For the genetics, okay. There is frequent amplification of chromosome 9p24.1, which is also associated with copy number gains of PDL1, PDL2, and also JAK2, all of which contributes to the pathogenesis of Hodgkin's lymphoma. Although many cases of these classical Hodgkin lymphomas show abnormalities of chromosome 14q, it is rare to identify translocation of 1418 in and also BCL2 rearrangement in B-cell non-Hodgkin lymphomas. Right. For the prognosis, actually the survival is quite good. 65% will survive within 10 years with treatment, and better prognosis in young age, in young patients, and also those with low stage of disease. Okay. So I think we have completed all on leukemia and lymphoma. Okay, half an hour earlier than expected. Okay. So far, I think you can understand what is written on my slide, right? Can you understand what is written on my slide? Somebody is answering. Are you still there?
Yes, Doctor.
Okay. So I think yes, there are many facts on leukemia and lymphoma. So unfortunately, you have to go. I have to go through each and every slides to get you through this lymphoma and leukemia lecture. So we have come to the end of the lecture. Do you need to ask me anything? Can you, because I can see only 29 here. I don't know. You said that there are 40 of you. Why kenapa hanya 29 kat sini? know why? Dah bagi tahu tentang ni kan? Dah tahu tentang apa ni lecture kan? Ke ada yang tak tahu?
Dah bagi tahu doktor dekat grup kelas.
Ya.
Mungkin dia orang ada masalah wifi kot. Tak tahulah.
Oh, lebih separuh Berapa tadi? 44? Mesti
40.
40. Oh, dalam 12 orang lah. Dalam 12 orang juga lah yang tak ada ni. Pasal 10-11 orang. Saya tak sure ni. Alright, so have you key in your attendance?
Yes.
Right. So can I end the session? Can I have a look at your face before we end? Can you put on your camera? Please turn on your camera. Every one of you. Boleh?